Thank you very much for having me. I'm really delighted to be here. So my name is Maya Sabatello. I'm an associate professor of medical sciences at Columbia University's Center for Precision Medicine and Genomics, as well as the Division of Ethics in New York. And I'm also a longtime advocate to promote disability rights and a researcher. And I have a research program that focuses on the ethical, legal, and social implications of genetics, focusing more specifically on marginalized communities, especially people with disabilities, and the uses and potential misuses of genetic information in clinical research and non-clinical settings.
That's really helpful, Maya. So one of the things that you've talked about before is precision psychiatry. Can you explain to us what that is, what that means, and what the current state of precision psychiatry is?
Yes, yeah. So precision psychiatry is one part of a larger scientific initiative called the Precision Medicine or Precision Medicine research. We're still in that phase. Historically, when we thought about biomedical research, it really focused on separately on issues such as public health research, looking, for example, at environmental effects on health outcomes. It looks separately on lifestyle choices, how smoking, diet might impact health outcomes. And then it had a separate arm of genetic research to identify biological-based differences in risk for certain diseases, such as cancer. Precision medicine research aims to offer a more holistic approach to health outcomes. It takes into account individual biological and genetic makeup, environmental factors, and lifestyle choices. That is, it brings the whole arena around a person, and its goals are to develop prevention, diagnosis, and treatment options that are tailored to each individual's biological, genetic makeup, environmental factors, and lifestyle choices. And so precision psychiatry, as I mentioned, is a type of precision medicine aiming to promote individually tailored prevention and treatment options for people with or at risk for developing psychiatric conditions.
So before we move on a little bit, one of the things that we at the Mental Health Foundation are very interested in is prevention. So it's very interesting to hear you talk about prevention in the context of precision psychiatry. Just briefly, where do you think we are currently on that as a goal, with maybe genetics as a tool?
Right. Well, frankly, I think that when we're thinking about prevention, the environmental aspects are most important at this point. When we think about the traditional mindset of genetics, we think about one gene causing a certain health condition. And in the context of common psychiatric conditions, that would be, for example, anxiety, depression, bipolar disorder, and so forth. But this is that's what we would have thought about if it was a traditional mindset. But psychiatric conditions are not following this traditional mindset. That is, anxiety, depression, bipolar condition, and other psychiatric conditions do not involve one gene, but they involve many genes, with each gene having only a small influence on any given outcome. Moreover, it is increasingly recognized that psychiatric outcomes or health outcomes and mental health outcomes are the result of not only these many genes, but also of many environmental factors that affect mental health and well-being. And that could include poverty, stress, wars, and other things that serve as triggers for certain mental health outcomes. And just to add to that complexity, we have to remember that these many genes and the many environmental factors interact both among themselves as well as with each other to produce the mental health or psychiatric outcome. So when we're thinking about it is where we are today, we are, for common psychiatric conditions, there is no one gene that can identify a condition or lead to prevention. And we are very far from knowing the genetic structure of such conditions. But what we do know is that there are certain environmental triggers that can impact health outcome. For example, using drugs, smoking the pot, alcohol use, significant social stressors such as poverty and so forth may trigger the outcome, and they interact with our genetic makeup. And so what we really need to focus on and put a great deal of focus on is really how we're dealing with environments in order to prevent the triggering events or to sort of reduce them once the trigger has started.
That's really helpful, and that's really helpful for us thinking about putting this in a public health, public mental health context. I know a lot of the work that you do is not in clinical settings at all. So it's not about, when we hear the word psychiatry, we instantly think about something that's going on within mental health services or within psychiatric services. And I know that you spend a lot of your time studying and doing work outside of those clinical settings. Could you give us an example or two of the kind of work that you do get involved in and the issues the ethical issues that might start to raise?
Absolutely. So yes, I think you're totally right. You know, when we think about genetic information, it has been historically conceptualized, and also today, obviously, it has a primary place in the context of clinical settings and how it might help or not prevent and diagnose and then treat psychiatric and other conditions. But what we've seen in the past few years is that there is a so-called geneticization of everyday life. That is, that genetic information about individuals is increasingly being brought into or considered in non-clinical settings. So, you know, the traditional places that we're thinking sort of in big scope would be, for example, the use of genetic information or being tested in direct-to-consumer genetic testing companies, the use of genetics in employment settings, and others. So the genetization of everyday life can also be obviously with psychiatric conditions, which is one of the areas of my focus. And just before we really jump into some of examples and the ethical issues that come up with it, I do want to sort of highlight very clearly that my studies are experimental. That is, we're using surveys and hypothetical case examples to explore the views of certain stakeholders on the uses of psychiatric genetic information in non-clinical settings. And that's very different than actually offering genetic testing for relevant conditions, which, as I mentioned, are often very complex and really not ready for use for the most part at this time. So in any case, my research focuses on the use of psychiatric genetic information in civil context, such as family court proceedings to determine child custody, the context of other civil courts, as well as the more research in the context of the use of psychiatric genetic and behavioral genetic more generally, which is actually a slightly broader term on educational settings. And I'll start just a little bit maybe with sort of general issues that come up in this context of the use of psychiatric genetic information in non-clinical settings, and then I'll focus specifically on family court proceedings and some of our findings. And you know, there's been a lot of concerns about the possible uses or misuses of psychiatric genetic information in non-clinical settings. One has been the concern of medicalization, or again, the geneticization of non-clinical settings, with worries that we're moving to consider human behaviors increased in daily life context as medical and genetic-based conditions that are subject to medical study, diagnosis, prevention, and treatment. And again, these are really non-clinical settings. So we're sort of expanding the world of medicine to everything that we do. And there's obviously a concern whether this is something we want to do. Another big concern that comes up in the context of the use of psychiatric genetic information in non-clinical setting is the worries about stigma and social exclusion, an issue that is particularly worrisome in the context of psychiatric conditions. We know that there's a lot of stigma and bias towards people with psychiatric conditions, and that this bias already has significant negative impacts on their lives, from employment opportunities to housing and social relations and so forth. So in the context of psychiatric genetics, there's a concern that introducing psychiatric genetic information about a predisposition to psychiatric condition or even about the presence of psychiatric conditions would lead to similar negative social impacts. And again, that's particularly worrying when you think about a genetic predisposition for a condition where there are no symptoms, there's nothing that should merit any attention or medicalization, and yet here we might have nonetheless social implications where genetics is immediately associated as a condition. And then related to these two words that I mentioned, that is the medicalization and stigma, there's been worries that the introduction of psychiatric genetic information may impact other life-changing experiences. And again, particularly in the context of child custody proceedings, the worry is that the introduction of such information would result in judicial decisions that are biased, such as taking away children from the parents who presumably or might develop psychiatric conditions in the future. So this is kind of the big picture, and when we think about child custody proceedings in particular, these are very difficult cases, right? They're often highly emotional, a lot of tensions, no one gets there by choice, and parents fighting over child custody often make real or baseless claims about the mental instability of the other parent in order to get an advantage in the judicial decision about primary child custody. So the question that I explored in my research is really how might the introduction of psychiatric genetic information in child custody proceedings may impact views about who is a mentally fit parent and which parent should get custody of the child. So again, here we surveyed a national representative sample of the general public in the United States, and we varied the information that they were provided in the vignette, in the case example, so that some participants received psychiatric genetic information about a parent who has been diagnosed with bipolar disorder, and other participants received the same psychiatric genetic information, but without such a diagnosis. Now, I'm pretty much simplifying it, but just that kind of the essence of the genetic component, which was really important for us. And we found both good and bad news. So I'll start with the good news, which overall, the introduction of psychiatric genetic information about a parent did not impact views about child custody decisions. That is, here we've been asking them, do you think that the parent who claimed that the other parent is not mentally stable should get primary custody, or should they have shared custody? And we didn't find a difference between those who received genetic information in the case and those who did not. The bad news, however, are that the introduction of psychiatric genetic information was strongly associated with perceptions of the parent having a psychiatric condition, here bipolar disorder, even in the absence of symptoms that were described sort of uniquely, or even just in the absence of a diagnosis of such a condition. And that came along with recommendations for the parent to see medical professionals, take medication, and even be evaluated for medical hospitalization. So again, if we think about the first concern that we had about the use of psychiatric genetic information in non-clinical settings, which is the medicalization of individuals, we see that clear picture that, at least from the public perspectives, psychiatric genetic predisposition is almost the same as having a psychiatric condition. And so that's obviously, and again, with all the ramifications of medical treatment. The second key finding that we had is that people who have high stigma towards people with psychiatric conditions, and we kind of measured it using various validated scales, they're also more likely to deny the parent-child custody or shared child custody. And stigma here includes people who expressed less willingness to interact with individuals with psychiatric conditions, such as friends, as co-workers, family members, or people who believe that people with psychiatric conditions are either more dangerous to the public, which we know it's a huge stigma and bias in the context of people with psychiatric condition, this perception that they're dangerous, as well as we had another measure to assess whether they thought about people with psychiatric conditions as capable or incapable of doing daily life activities such as opening a bank account, marrying, signing a contract. And again, also here, we found that people who had high stigma in either one of those three areas of less willingness to interact, perceptions of dangerousness, and perceptions of incapacities or incapabilities, lack of capabilities, were all more likely to deny the parent who was presumed to have a genetic predisposition to psychiatric condition, to deny that parent child custody, shared child custody. And then finally, the third and sort of more broader, more general finding that we had is we've also measured issues of implicit bias, which, you know, there's been a lot of changes in the past 2 decades and a lot of efforts to teach the public and educate the public about the biases and stigma that exist. And so there's studies that have been showing that people are less likely today to acknowledge or to explicitly say that they have biases. But when you go into the implicit bias, that's something that's measuring your unconscious bias. So you're not really controlling it. You don't know what you're measuring until you kind of end the results. And we created here a tool to assess the implicit bias with respect to parents, with respect to people with psychiatric conditions and good or bad parenting. And here what we found is that there was a very strong association between parents with psychiatric conditions and bad parenting. So parents with psychiatric conditions are presumed to be cold parents, they're presumed to be more neglectful, irresponsible, and even dangerous parents. So now again, I think it's important to remind everyone that our study was hypothetical, and our participants were members of the general public, not the judges. And I certainly hope that judges are more educated about the abilities of parents with psychiatric conditions, and ideally also about where we're standing in terms of the scientific knowledge of psychiatric genetic. Again, i.e. that today efforts to introduce evidence about a parent's psychiatric genetic predisposition for common psychiatric conditions really be rejected, with the understanding that such data has weak predictive validity at this point, especially in the absence of symptoms. But this aspect of stigma and bias are really significant, and although genetic evidence in court proceedings really did not have a direct impact on child custody decisions, I think the overall worry here is that it creates some sort of a cycle, and it plays a role in a cycle, because if we're medicalizing, if the genetic predisposition for common psychiatric conditions medicalizes the person, regardless of symptoms or not, then the diagnosis itself, as well as those behaviors that are presumed to be due to psychiatric conditions, are associated with denial of shared custody, then it's kind of a cycle that the worry is that really psychiatric genetic information might have negative impact on parents, and again, that's unjustifiable. I don't know if you want me to move to a second example, or if you have any other questions sort of before we move forward.
No, I think that's really helpful and really useful. So yeah, give us another example.
All right, that sounds great. So the other area that I've put quite some time into in the context of psychiatric genetics, or even behavioral genetics more broadly, is really the educational settings, which I hope perhaps may give a more optimistic outcome, although I definitely think that we have to still have a lot of areas that need to be explored, and we're still in processes of doing other studies. But again, also here we used a similar research design with parents and the general public participants in the United States, taking a survey that introduced a child with or without behaviors that are associated with ADHD. It's obviously one of the most common conditions that are being diagnosed among children. In the United States in particular, the numbers of children who are diagnosed with that conditions is very high, and we introduced them this information about a child, a 5-year-old kid, I think, boy, who might have those some behaviors that are associated with ADHD, along with the possibility for the parents to test the child for psychiatric predisposition for ADHD, and two, once we introduce then sort of genetic test results, again, all hypothetical, we provided some participants with information that suggests that the child has an increased risk for such a condition. And then we had more questions. And what we were interested to know is, one, whether parents and the general public would want to have their child being tested for ADHD in the context of education, and two, whether the introduction of such data in the context of educational settings will impact the views about child's eligibility for special ed services. Now, both points need maybe some more clarifications. One, because there's a big question as to who should make decisions for children about genetic testing, especially when we're talking about genetic predispositions, and especially when we're talking about genetic predisposition for psychiatric conditions. And so that was one big question that, of course, we have to think about. Is it the parents' decision whether to test their child? Should it be the school system that decides which children should be tested? And then again, that's a big question. And the second part of how it might affect eligibility for special ed services, obviously there are increasing number of state laws and national laws that require accommodations and services for children with disabilities, with a goal of inclusion and really bringing them into the mainstream education rather than separate education. We know, however, that the road to special ed services is not smooth. Very often it involves many applications, many appeals, many requests, back and forth efforts to tailor the services to the child's needs. But very often parents really struggle with getting ahead and getting those services. And so part of the question from us, and again, we're coming from the United States perspective, right? We have a very privatized system in so many things, and even though public education and private education are required to provide accommodations, again, the road to getting those services is still very often contested and difficult. So again, here too, we found that the introduction of psychiatric genetics, so let's start with that one, parents overwhelmingly wanted to have their child tested to the hypothetical ADHD gene. That was kind of interesting. However, the overwhelming majority would not want others to make that decision for their child. So that was a very clear thing. The other thing that we found is, as with the example of the child custody disputes, is that the introduction of psychiatric genetic information medicalized the child. So here again, we found that once those participants who received information about the psychiatric genetic predisposition were more likely to think about the child as having a disability, and with more expectations that the child should see a medical professional and possibly get medication. Although I would say that the medication part was not as supported in the context of children as it was supported in the context of adults. The other good, and that's kind of part of the bad news here, I would say. However, I will say that on the good news side is that there was an overwhelming support, both among parents and the general public, for the child to get services for educational development and special services regardless of the introduction of genetic information. And more generally, participants in our studies, both parents and participants from the general public, associated educational achievements more closely with environmental factors, such as nurture, training, experience, neighborhoods, rather than with the genetics and hereditary factors. So that's, I think, a more positive picture than what we previously saw. And I think in other studies, we also find that there's a difference between how the introduction of psychiatric genetic information may be seen when it is about a child versus about adults, possibly because children are still seen as more malleable and, perhaps with less control over their behaviors overall, versus adults who are expected to have more control and individualized controlled and so forth. But again, there was a very, I mean, it was good to see that hopefully we have been able to make changes here in the perceptions that special service educational services, and I don't even like the special, it's just that educational development services are really for everyone, right? Now, there are of course more things to look at, and I would say that our studies to date have not fully looked into them, although we touched but didn't really find anything in particular. But for example, the question of whether or not this general attitudes towards supporting children in their educational systems, whether this approach applies across racial groups, given the added stigma and discrimination against people of color. And again, just looking at the United States, children, Black children, are far more likely to be diagnosed with psychiatric behavioral conditions than white children. They are far more likely to be placed in separate education systems. And again, whether or not the positive assumption that the environments are so important for child's development would be the same is something to look at. We have another study that I'm currently conducting with colleagues, and that touches on some of these issues, and I do not yet have findings about that, but hopefully we'll have some good findings and news to share there as well.
It's been really, really informative and helpful, and I think it's prompted a lot of thinking with people. Are there any kind of final thoughts you'd like to leave people who many of whom will be philosophers who want to really kind of ponder some of the ethical issues that may be coming up, or even mental health professionals who might be worried about what's coming over the hill in terms of their practice? Any kind of quick final takeaways that you'd like to leave with us?
Thanks, David. So I want to say a couple of things, and all the findings that I've shared have some negative context to them, but I do want to remind everyone that genetic knowledge is growing. It is promising for treating various medical conditions and might have a lot of a say in psychiatry as well in the future. And so I don't want, especially when we're looking at precision psychiatry and the more holistic approach, so I really do not want us to lose track of this promise. However, I do want to stress out that when we're thinking about the use of psychiatric genetic information in non-clinical settings, I do think we have to be thinking about the next steps. And I think one thing that really we should think about is how do we increase education about psychiatric genetics among the general public, among parents, and among mental health and other professionals. These are folks that usually serve significant roles both in child custody courts, disputes, as well as in the context of education. And again, insofar as that they might not know these issues about the scientific validity of psychiatric genetics, it's important for them to know. And it's also, again, very important to remind everyone that genetics is not a destiny, that there are many environmental and lifestyle factors that will affect health outcomes. And again, I think that's very important. Then a second sort of concluding remark is that we need to be cautious about how this information is being used. And again, and especially in non-clinical settings, we don't need psychiatric genetic information to make the case as to why children should be given good and supportive educational systems. All of them should have such access. I think there are real concerns about the misuse of such data and how it might reinforce misperceptions about abilities of people with psychiatric conditions. And we really need to start creating systems and measures to address the potential misuses of genetic information. And again, think about that in the future, it might be possible that you would leave a cup of drink in a coffee place and someone will take it and test it, right? This is not the things we want to have, so we really have to create measures and regulations to protect from that. And then finally, I really want to emphasize the need to de-bias perspectives and to address the stigma against people with psychiatric conditions. I think that our findings that irrespective of psychiatric genetics, a psychiatric diagnosis or presumed behaviors have such an impact on perceptions of legal capacity of relevant parents to make daily life decisions, again, such as opening a bank account or signing a contract, and the association between parents with psychiatric conditions and bad parenting are really troubling. And I think we need to educate our judges, our public, our mental health professionals, anyone who is involved in those procedures, and find effective ways to reduce stigma against people with psychiatric conditions.
Maya, I think that's a